22 years female Anushya Chaudhary, a housewife from Kalyan, was admitted in this hospital on 23rd of April 1919. She came with history of 4 months anemia, complaining of pain in abdomen and PV bleeding since one day.
What are the causes of bleeding in early pregnancy?
Abortion, heredity from womb, and ectopic pregnancy, and other conditions like cervical erosion or carcinoma of cervix. Patient had initially spotting, then the bleeding increased in quantity and is bright red in color. No history of passing vesicles.
What does the fresh red color indicate?
It indicates that there is active bleeding. In cases of missed abortion, bleeding is altered in color. Menstrual history, menarche at 13 years of age, regularly menstruating woman with 3 to 4 days flow for only 30 days. Last menstrual period on 4th of January 1990. Obstetric history, married 3 years back, Gravida 2, Para 1, Living 1, no abortions. Gravida 1 was full-term normal hospital delivery, 2 years male living. Gravida 2 is present pregnancy. No history of diabetes, hypertension, tuberculosis in past. No history of any significant major illness in family. Sleep appetite is normal. Bowel bladder habits are normal. On general examination, averagely built and averagely nourished woman, her height is 152 centimeters, weight is 46 kilograms. Pulse is 90 per minute regular, good volume. Blood pressure is 110 by 70 millimeters of mercury. There is mild pallor and no edema. Respiratory system is normal. Heart sounds are normal. No murmur. For abdominal examination, on inspection, striae albicans and luminea nigra are seen. Uterus is burst palpable at symphysis stages. Mild tenderness in hypogastria is present. No guiding rigidity in the abdomen.
What is your diagnosis?
This is a case of second gravida with 4 months anemia with PV bleeding, probably due to inevitable abortion.
Why not hereditary from womb?
Because the bleeding is fresh, contains no vesicle, and the height of uterus corresponds to the period of gestation. However, the diagnosis will have to be confirmed by further examination and investigation.
What is your differential diagnosis?
Inevitable abortion, threatened abortion, or missed abortion, and vesicular mole.
How will you confirm your diagnosis?
First, I will do per speculum and per vaginal examination.
What different findings will you look for?
In case of threatened abortion, there is minimal bleeding with cervical os closed and uterine size corresponds to the period of gestation. In case of inevitable abortion, there is active fresh bleeding with open cervical os. In case of missed abortion, the bleeding is blackish and altered in color. Signs of pregnancy will be reversed. There is breast secretion and congestion of genitals will be regressed. Uterus will be firm in consistency and smaller than the period of gestation.
And what are the findings in case of vesicular mole?
Patient generally presents with hyperemesis gravidarum and recurrent PV bleeding. On examination, the patient is pale. She may have hypertension due to early development of preeclamptic tonuria. Uterus will be larger than the period of gestation and of body consistency. External development is absent. No fetal parts are felt and fetal heart sounds are not heard.
What investigations will you do?
I will first investigate her blood for hemoglobin, blood group RH and VDRL, urine for albumin and sugar. Then to confirm the diagnosis, I will do ultrasonography.
What findings will you get on ultrasonography?
In case of threatened abortion, normal fetus with intact placenta will be seen. In case of inevitable abortion, cervical os is seen open and there may be other evidences such as placental separation or intrauterine death of the fetus. In case of incomplete abortion, few products of conception will be seen retained in the uterus. In case of vesicular mole, there is no storm appearance and in 25% of cases, luteal cyst of ovaries will be seen.
Which other tests can be used to diagnose a vesicular mole?
Urinary pregnancy test is positive in very high dilution, that is 1 in 300 or more. Quantitative HCG assay shows very high and rising values. If fundus is larger than 16 weeks, X-ray examination shows no fecal shadow. An amniography shows soap bubble or honeycomb appearance.
How will you treat this case?
Since clinically this is a case of inevitable abortion, I will confirm the diagnosis and then do dilatation and evacuation under general anesthesia.
And how will you treat a case of threatened abortion?
I will hospitalize the patient, give her strict bed rest, tranquilizers to relieve anxiety, uterine relaxants like isoflurane that is duodenum, and progesterone in cases of progesterone deficiency.
How can you diagnose progesterone deficiency?
The perpendicular staining of vaginal cytology to detect progesterone effect, and if available, progesterone assay can be done.
Which progesterone do you prefer to give in pregnancy?
17-alpha hydroxyprogesterone, which is a pure progesterone devoid of testosterone-like side effects. The other progestogens will give rise to minimization of external genitalia of female fetus.
How will you treat a case of incomplete abortion?
First, depending upon blood loss and general condition of the patient is resuscitated with intravenous fluids and blood transfusion. Then dilatation and evacuation is done under general anesthesia.
What is the treatment of vesicular mole?
Once vesicular mole is diagnosed, it should be evacuated immediately.
How will you evacuate the uterus?
If the cervix is undilated, it is dilated by laminated and then evacuation is carried out preferably by suction current. Syntocinon drip and augmentin are given to contract the uterus. Evacuation with ovum-healing process will cause excessive bleeding and hence avoided.
You will not send the specimen for histopathology?
Yes, sir, but the specimen should contain the last created material from the walls of the uterus.
Why?
Because first evacuated portion of the mole is necrotic, while the peripheral villi are in active process of development. So the specimen of the peripheral villi should be studied histopathologically to diagnose whether the mole is benign or malignant.
How will you follow the patient of vesicular mole?
The repeat curettage is done after 7 days to see trophoblastic activity. Patient should not become pregnant for 2 years after a vesicular mole. Initially, patient is followed monthly for 3 months, then 6 monthly for next 2 years.
What investigations will you do in the follow-up?
I will examine her to watch the size of uterus. I will take X-ray of her chest to look for metastasis and quantitative pregnancy test to know the trophoblastic activity.
What are the risk factors in vesicular mole?
The high risk factors for development of choriocarcinoma in a case of vesicular mole are age more than 40 years, high parity, complete mole, ovarian enlargement more than 6 cm, and high titer of HCG.
How will you treat a patient of high risk?
Prophylactic methotrexate should be given in dose of 15 mg per day for 5 days, and patient should be regularly followed up. In case of invasive moles and if the age is more than 40 years, abdominal hysterectomy may be advisable.
Why does a hydatidiform mole occur?
Hydatidiform mole occurs due to transformation of chorionic villi into a mass of translucent vesicles. The exact cause is not known, but it is often associated with chromosomal abnormalities like triploidy in partial moles and dual set of paternal genes in complete moles. Normally, the trophoblastic activity is controlled by the mother's immune mechanism. This control may be lost due to altered immune reaction or due to malnutrition and debility.
How does a hydatidiform mole look?
On birth examination, uterus is filled with large number of translucent vesicles of varying sizes. On histopathological examination, the three features of vesicular mole are trophoblastic proliferation, hydrotic degeneration of connective tissue curve, and avascularity of villi.
What is the pathogenesis of vesicular mole?
The fetus dies inside the uterus and the villi become avascular, but the placental blood supply continues and villi are overloaded with fluid and nutrition, which causes proliferation of trophoblasts.
What are the complications of hereditary form mole?
Hemorrhage, infection, perforation of uterus, metastasis, and choriocarcinoma.
Can you tell me the causes of abortion?
Fault in ovum or defective germplasm and chromosomal defects. Then maternal diseases like hyperthyroidism, diabetes mellitus, syphilis, chronic nephritis. Maternal trauma, direct or psychological or surgical, and anesthesia. Hormonal deficiency like progesterone deficiency and local diseases like uterine anomalies, fibroid uterus, or cervical incompetence.
What are the different types of abortion?
Abortion may be spontaneous or induced. Spontaneous abortion may be threatened abortion, inevitable, incomplete, missed, and habitual abortion. An induced abortion may be a medical termination of pregnancy or criminal abortion. And any abortion complicated by uterine sepsis is septic abortion.
What is the commonest cause of habitual abortion?
Cervical incompetence.
How will such a patient present?
Patient will present with recurrent painless mid-trimester abortion. First, there will be rupture of membrane followed by spontaneous abortion.
What is the etiology of cervical incompetence?
It may be a congenital weakness or may be acquired due to repeated dilatation of cervix, cervical high amputation, cervical prolapse, etc.
How do you treat such cases?
First, fetal anomalies are ruled out by ultrasonography, and at 14 to 16 weeks of pregnancy, either McDonald or chirurgical cervical encerclage procedure can be done.
What are the differences in these two methods?
McDonald is a simple method of taking a bursting stitch at the level of internal os, and in chirurgical's method, bladder is dissected anteriorly and a submucosal stitch is taken at the level of internal os, so chances of bladder constriction are less. Progesterone supplements are given if required, and bed rest is advised till term.
How will a patient of ectopic pregnancy present?
Patient usually has a long history of infertility and history of pelvic inflammation or tubal surgery. If ectopic pregnancy is unruptured, then patient presents with amenorrhea, pain in abdomen, and recurrent PV bleeding.
Why is there pain in unruptured ectopic?
Because generally it is a tubal ectopic pregnancy, and tube is a hollow muscular organ which contracts in an attempt to expel the pregnancy, resulting in pain.
And why is there recurrent bleeding?
Because in ectopic pregnancy, progesterone is not produced in sufficient quantity to support the endometrium.
If the ectopic is already ruptured, then how will the patient present?
Patient with history of amenorrhea gets sudden agonizing pain in abdomen. Some patients may have a feeling of something given way in lower abdomen. She will be in shock due to intraperitoneal hemorrhage, tachycardia, low blood pressure, cold extremities, sweating, and severe pallor. Tenderness and guarding will be present over abdomen.
How will you confirm the diagnosis?
By colpopuncture, which shows frank blood in peritoneal cavity which does not clot.
Why does this blood not clot?
Because it is already clotted blood liquefied by fibrinolytic activity and containing FDP or fibrinogen degradation products.
How will you treat such a patient?
By blood transfusion and immediate laparotomy for salpingectomy. Once the bleeding is stopped, patient will recover quickly. During laparotomy, we can give autoblood transfusion to the patient if the bleeding is recent.
How do you give autoblood transfusion?
The blood in the peritoneal cavity is collected and under aseptic precautions is filtered through 6 layers of gauze and collected in an acid-cited dextrose bottle.
What is an ectopic pregnancy?
Ectopic pregnancy means implantation of a fertilized ovum over the site other than uterine cavity. So it can be a tubal pregnancy, ovarian pregnancy, primary abdominal pregnancy, pregnancy in the rudimentary wall of the uterus, or cervical pregnancy.
Which is the commonest?
Tubal pregnancy comprises about 95% of the cases, out of which ampullary pregnancy is the commonest.
What is the etiology of tubal ectopic?
Chronic pelvic inflammation giving rise to peritubal adhesions and tubal blockage, which is the commonest cause. Previous tubal surgery like recanalization, congenital hyperplasia of tube, pelvic tumors distorting the tube, and previous history of ectopic pregnancy.
This is the end of the 8th clinic in obstetrics on bleeding in early pregnancy.